Hi, welcome. Good afternoon, everyone. Thank you all so much for being here for our September Arizona Community Grand Rounds. This session is on maternal mental health, Arizona resources, and best practices. I'm very excited to dive into this session today and to hear from our fantastic experts. First, I'd like to extend a thank you to our partner, the NARBA Institute, who is instrumental in making Arizona Community Grand Rounds possible. And of course, to our partners to help put this together, Mary Jo Gregory, Dr. Mark Carroll, Carla Berg, and Jennifer Pierce. This wouldn't happen without you. For those of you on the call, please make sure you stay to the end. At the conclusion of this presentation, we'll share information with you about how to receive your CEUs. And now it's my pleasure to introduce our speaker panel just with a brief summary of their very impressive bios. First, we'll hear from Caitlin Skeens. Caitlin specializes in the diagnosis and treatment of perinatal mood and anxiety disorders. Raised in the Pacific Northwest, Caitlin, her husband, and their children relocated to Arizona in 2017 to be near their most supportive family members. Caitlin's personal birth stories encompassing loss through miscarriage and 4 live births inspired her commitment to empowering, supporting, and nurturing mothers and families. Through fertility complications, healthy pregnancies, and the turbulent transition of the perinatal and postnatal periods, Caitlin's dedicated to promoting the wellness of families with compassion and grace. She completed her undergraduate degree in psychology with a minor in addiction studies from Washington State University. And from there, Caitlin discovered her passion for understanding the complexity of human emotion and behavior. She has her Master of Science in Professional Counseling from Grand Canyon University, and a drive to be a champion for mothers by achieving certification in treating perinatal mood and anxiety disorders through Postpartum Support International. She's received specialized training in the art and neurobiological science of brain spotting for perinatal populations. And Caitlin is currently credentialed and licensed in the state of Arizona as a licensed professional counselor. After we hear from Caitlin, we'll hear from Dr. Saira, Kalia, who is a renowned perinatal psychiatrist, and educator, currently serving as the director of APAL, which is the Arizona Psychiatry Perinatal Access Line. Dr. Kalia's impressive career includes pivotal roles at Banner University Medical Center, where she's made significant contributions to perinatal psychiatry. Dr. Kalia initiated the perinatal psychiatry training track and clinical service within the psychiatry department, expanding the department's capabilities. She's a national trainer for Postpartum Support International and contributed to the National Curriculum of Reproductive Psychiatry. She's also an author of the textbook of Women's Reproductive Mental Health by the American Psychiatric Association. Dr. Kalia was recognized as an outstanding educator and received the Howard E. Wesleyan Excellence in Education Award in 2020. Her patient-focused care and dedication to education have earned her a stellar reputation, not just in Tucson, but across the state, where she's received numerous accolades for her clinical and administrative contributions. So now, before I turn the floor over to these talented individuals for remarks, I'll just remind all of you that you can feel free to use the Q&A function to send questions our way. After each of our presenters provides her initial comments, we'll dive into all of the discussion. First, I'd like to turn it over to Caitlin, though. Caitlin, the floor is yours.
Okay, thank you so much, Jessica, and thank you for having me to speak here today. So I will go ahead and start talking about just what are PMADs. So, you know, everybody's heard the phrase, you know, postpartum, if we can go to the next slide. Everybody's heard the phrase, you know, postpartum depression, or I had postpartum, quote unquote, is kind of what you'll hear most people say when they're talking about this issue. And really the clinical terminology is PMADs, which stands for perinatal mood and anxiety disorders, which really encompasses the whole issue more appropriately and accurately. So perinatal is just a word that means a time period. It's the time period of pregnancy through 1 year postpartum. And oftentimes this is even considered you know, the time during which a family is trying to conceive. So in that sense, you could consider it pre-pregnancy through 1 year postpartum. And then mood would be, you know, various mood disorders such as depression, bipolar disorder, psychosis. And then anxiety disorders is another component, which is actually anxiety disorders are more prevalent than depression. So that includes generalized anxiety, panic disorder, OCD, and PTSD. And then, you know, it being a disorder simply just indicates that it interferes with their functioning. So it's not just postpartum and it's not just depression. It's the whole time period, and it can be any of these presentations. So I'm just going to speak briefly about just some prevalence rates, and you know, kind of what this issue is looking like in our state. So PMADs are the #1 complication of pregnancy and childbirth. Nationally, it affects 1 in 7 pregnant and postpartum women. I will say this is a pre-COVID statistic, and so we think it's actually much higher than this. We know irrefutably that 1 in 10 dads are affected by postnatal depression, which is a kind of shocking statistic to a lot of people. So half of all perinatal women with a diagnosis of depression don't get the treatment that they need. So, you know, you can see that like there's a small, you know, kind of window of women that are getting the help that they need. And just the cost. So untreated perinatal mood and anxiety disorders in the US are extremely costly, and there's multi-generational consequences that affect, you know, the child and for generations to come. So an estimated $14.2 billion for all births just in the year 2017 is kind of the estimated cost of untreated PMADs in our state. And this is just kind of an interesting sort of elaboration on the previous slide. So, you know, it is the most prevalent pregnancy complication, and yet, you know, it's rarely tested for. So perinatal mood and anxiety disorders, they're more common than gestational hypertension, preeclampsia, gestational diabetes combined. You know, and for any of you that have either been pregnant or seen someone pregnant, you may remember, you know, the pink drink. That's a test that 100% of women get for, you know, testing for gestational diabetes. But we're talking about something here that's more prevalent than that, and more prevalent than those other top pregnancy complications combined. And it's not getting the screening that's necessary. On the next slide here, I'll just briefly talk about maternal mortality. So almost all pregnancy-associated deaths are related to mental health or substance use, and 98% of them are considered preventable. And so these are statistics that sort of encompass 2016 to 2018, you know, of women in their childbearing years of age 15 to 49, who had a pregnancy within 365 days of their death. And 98% of them are considered preventable, either, you know, a good chance to prevent or some chance to prevent. So, yeah, #1 complication of childbirth and pregnancy. It affects 1 in 7. Again, that's a pre-COVID statistic, so we're thinking it's much higher than that. On the next slide here, you can see that 1 in 3 moms of color will experience perinatal mood and anxiety disorders, and so this is a huge need, especially in our community. 1 in 10 dads will be affected by perinatal mood and anxiety. And you can consider that this is a similar impact for all non-birthing partners, regardless of their gender identity. I'll just kind of breeze over some risk factors here. So certain history indicators may be kind of a yellow flag here. So a person's going to be at an increased risk for a PMAD if they have personal and family history of depression, anxiety, bipolar disorder, psychosis, diabetes, thyroid issues, that kind of a thing. So if there is a, you know, mental health background, either with the person themselves or within their family of origin, that's a risk factor. PMS and PMDD as well. Infertility is a big one. Families who struggle through the fertility process are at an increased risk. And then there's other pregnancy and birth factors, such as having a traumatic pregnancy, delivery, you know, any kind of infant loss, multiples, NICU stays, challenging Challenges with breastfeeding is another huge one. And then just consider life stressors. When you have a baby, life still goes on outside of the context of, the small circle of your family. And so, relationship issues, being a single mom or a teen mom, not having the support system you need, and other major life events. Just a little bit of what these things can look like. So perinatal depression oftentimes looks like anger or irritability. I think some of us may have heard the term mom rage. And a lot of times, what's really underneath that is depression or anxiety. So it could or could not look like lack of interest in the baby. That is sometimes a present factor. There's oftentimes appetite, sleep fluctuations, tearfulness, sadness, spells, guilt, shame, hopelessness, loss of interest, that kind of a thing. About 15% of perinatal mood anxiety disorder cases have significant depression postpartum. And I just want to note here that this is very, very different than the baby blues. So that's kind of an older term that people still use, but really that is primarily about the hormonal shift, the huge hormonal fluctuation. It affects most moms. It affects most birthing people, about 80%. But it really only lasts about 2 weeks. So I kind of like to tell people that if, something is still going on, or you're still just not quite feeling yourself, and it's been more than 2 weeks after you had your baby, there's a good chance something else is going on here. So postpartum depression and the baby blues are not the same thing. Anxiety presents oftentimes like worry, racing thoughts, staring at the baby all night, making sure the baby's still breathing, that kind of thing, and then other physical symptoms. Anxiety can also be like postpartum panic disorder, postpartum OCD. This is kind of surprising to a lot of people that, you can never have had problems with OCD, or sometimes never have had problems with anxiety at all, but it can fully present for a person after they've had a baby. And so, that can look like repeated behaviors, repeated thoughts, knowing that, they're feeling fearful about something, but not feeling as though they have the control to be able to stop researching things or checking the bottles, or that kind of thing. And the next slide here is about PTSD. So oftentimes this is related to the birth itself. It can be related to other things as well, a difficult pregnancy. If a person has had a previous trauma in their lives, they're going to be at higher risk for this. But this happens when a person experiences real or perceived trauma during delivery or postpartum. Kind of the hallmark here is that the person feels powerless. So it's not really about what happens as much as it is about whether or not they feel they have power in this situation to kind of control what is happening. And so, it's kind of typical PTSD symptoms here, re-experiencing flashbacks, anxiety and panic, that kind of thing. And I'm not going to talk too much about bipolar disorder or psychosis. I'll just say one quick thing about this. 50% of birthing people with bipolar disorder it's their first diagnosis. They experience this diagnosis for the very first time postpartum. So oftentimes when we're talking about postpartum bipolar, it's not like you have to have had bipolar before you had a baby. For like half of moms, they've never had this present before, and then they have it present after they've had a baby. That's kind of put in a similar category as the psychosis, because sometimes the mania can look like psychosis, and sometimes it doesn't. But psychosis very much is what's important to know about this is that postpartum psychosis is a medical emergency. It is delusions, strange beliefs, paranoia, hallucinations, seeing, hearing, believing things that are not there. Oftentimes the onset is sudden within the first 2 weeks postpartum, but it doesn't have to be that. I know this has been kind of a hot topic in sort of like the news and media this year. There's been some instances of, of this throughout our nation. And what's important to know here too is that it's very rare, but it does happen. It does absolutely happen. And so I'm going to talk more about referrals here in a moment, but psychosis is a medical emergency where a referral needs to happen right away. I'll share here on this next slide. This is just a discussion tool, and I think that the slides are available to anyone who's here. So if you click the link, you can have access to this discussion tool to kind of guide you in how you might have this discussion with someone that you suspect may be struggling with a PMAD. On the next slide here, talk about PSI, Postpartum Support International. We have an Arizona chapter, and we provide, support in kind of 4 main areas. So we provide direct support for families, support for providers who are supporting families, education and training for professionals, and then advocacy and outreach. And so first I'll briefly touch on support for families. So these are some things that you can, as providers, give to your clients, patients. So PSI has a helpline and volunteer coordinators. So one more slide forward, if we could. Oh, one more, there it is. So that's our helpline, and it's a toll-free number. Anybody can call it. You can text help to get basic information and support from it's not a crisis line. So that's what's important to know. It is a warm line. So oftentimes, you call, I think they say within, 3 or 4 hours that you can get a call back. It's usually not that long, but it is operating every day of the year, 24 hours a day. It just sometimes takes a little while for them to get back to you. So it's not a crisis line, but it is a helpline. And volunteers who are trained in perinatal mental health are available to speak with you, to speak with the family, whoever needs the support in that time. And then of course there's the National Suicide Prevention Lifeline that is more appropriate for an immediate crisis situation. Then we have the National Maternal Mental Health Hotline. You can see the number there. PSI also has support coordinators. So statewide in Arizona, you can see the link there will show you how to access a support coordinator in your specific area. But they provide specialized support, and they help link you up to specialized referrals you may need to either find for your patients or whomever. You can also give this information directly to clients or patients for them to access themselves. But you can see there some of the specialized referrals that the support coordinators can help provide. PSI also offers online peer support groups that are completely free of charge, and they're pretty specialized. So we have, Black Moms Connect, Dad Partner Support, queer and trans support. You can see there's specialized support groups, and you can see the link there for their frequency and availability and things like that. You do have to register, but it is free of charge. And then there's an online peer support group as well. Support for pregnancy and infant loss, fertility challenges. We also have these groups in Spanish. Yeah, I won't read through each of those. You can kind of see there. We will offer, PSI also offers support for dads. And so just to reiterate, like 10% of dads do experience postpartum depression, and about 20% of dads have an anxiety disorder after bringing a new baby into the family. And so, PSI is pretty passionate about not just supporting birthing mothers, but partners and dads as well. PSI has a mentor program. You can see that there. So for parents that are struggling with perinatal mental health issues, the program kind of pairs them up with somebody who themselves is someone who's had lived experience with PMADs, and they communicate with them on a regular basis and kind of help them navigate that season. And you can chat with an expert. So there is a phone chat that's led by a licensed mental health professional who provide clarification and answers. And this is support for families. So, if they want to not necessarily just talk to a volunteer, they want to talk to a mental health professional who's licensed, they can utilize this resource. And then just really quickly, I'll talk about support for providers. I'm going to let Dr. Kalia talk about APAL here, but what I will speak to is the PSI Perinatal Mental Health Provider Directory. So PSI keeps a directory of professionals who have been through perinatal mental health training, whether it just be sort of the standardized like 2-day training or it be more specialized advanced training. They kind of have all of that available. You can see, how do I find a therapist who's trained and versed in, what it is that I'm going through or what my patient is going through, and or how do I find a prescriber that knows this population. And so you can search by zip code, and it's a really handy little resource. Education and training. So PSI offers Maternal Mental Health 101, which is just a free 90-minute webinar. We also have certificate trainings, and so these are kind of the different sort of levels of training that are offered on the next slide, actually. So 2020 Mom offers a fully online maternal mental health certificate, which is equivalent to the training that PSI offers, which is just a 2-day certificate training. If you are pursuing the PMHC, which is a perinatal mental health certified professional, you need to take an advanced training. There's 2 options for that, either the advanced psychotherapy for therapists and affiliated professionals, or the advanced psychopharmacology for prescribers. And you can see a quick map there of, the takeaway here is that Arizona is a maternal mental health desert. Our entire state does not have enough providers in any county. And, it's just kind of like which counties are worse than others, but it's all not great. The professional in each county, if you look at Maricopa, for instance, for all of the PMHCs in Maricopa County, to serve everyone who has a need, they would have to see 250 to 500 patients a year to meet that need, which just isn't reasonable. On the next slide here, you'll see kind of the track for the PMHC, and we can come back to that if there's interest or questions in how to pursue that. And with, PSI's kind of stance here, you're not alone, you're not to blame, with help you will be well. And just a couple of ways to contact our chapter. And then lastly, I just want to thank Blue Cross Blue Shield for their support, because the Blue Cross Blue Shield Arizona Foundation for Community Health and Advancement has awarded PSI Arizona with a grant that has allowed us to have the first ever BIPOC training specifically for people of color in our state. And we're really grateful for the support of Blue Cross. So that's all I have.
Caitlin, thank you so much. Those were phenomenal resources that you shared, as well as just a really great background and overview of why this is important. So thank you very much. And we will send an email out after this too that has links to resources as well, for those of you who weren't able to capture them all during the course of the presentation. But now I'd like to turn it over to Dr. Kalia to share additional information with us. Dr. Kalia?
Thank you so much, Caitlin. That was fantastic. Thank you for making it easy to follow you. So I am going to talk a little bit about innovative approaches to the treatment of maternal mental health care. I'm going to jump around a little bit in regards to the slides. So I'm going to go to just first disclosures. I'm a person of color. I'm an immigrant. I've had serious health challenges. the healthcare system in the US in general is not a pleasant system to navigate, but when you kind of have to navigate it as a birthing person in your reproductive time frame, it becomes quite significantly more challenging just because of various aspects of our healthcare system. So I'm going to talk a little bit about maternal mortality. So if we could go to, I think it's slide 2 or 3, slide 3. So when you go to, when you think about maternal mortality in the US, and this is maternal mortality, not mortality due to maternal mental health. Maternal mortality in the US far outstrips that of other industrialized nations. So we're in the double digits, 23.8, whereas while you can see other industrial nations are under 10. So they're in their single digits, which is a pretty shocking state to be in. There was a recent report that went out in 2023 from the US Maternal Mental Health. So they gave out state report cards on maternal mental health, and they were not pleasant to look at either. The national grade we got as a country was D. Only one state managed to exceed that and get a C+, which was California, and so California got I think it was a B- or a C+. Only 5 states had C's, and 40 states and DC received D's and F's. And I'm sure everybody's like, where was Arizona? Arizona got a C actually. Which is better than the national average of D, but not the aspired aspect of, and not what we aspire to. And as an Asian mom, definitely not what we aspire to. The few reasons why Arizona did better with regard to the rest of the states is we have some requirements for provision of direct mental health services, maternal mental health service. We have a state maternal mental health task force or commission, which other states don't have. And apparently our maternal mental health prescriber to patient ratio is not as awful as the rest of the country, as the rest of the countries. It's pretty awful still. I'll get to that in a second, but those were some factors of it as well. The areas that we did fail on, that as Caitlin mentioned, the PMH-C provider to patient ratio is pretty horrific for us. We don't have any inpatient perinatal mental health treatment program in the state, and we have very, very limited outpatient intensive or partial hospitalization programs. There have been 1 or 2 that are dedicated purely to that perinatal time period, but because that's such a tough program to maintain, they tend to kind of become more inclusive over time. And so those are kind of the areas why the state has shifted in terms of our grade, things that have lifted us up and things that have lifted us down. The one thing I will say is, though, even though it's horrible, Arizona is kind of cool in the sense that we are trying. There's a lot of effort that's dedicated towards maternal mental health work, and there's a lot of expansion around it as well. Recently, Access has figured out how to tag perinatal mental health care, the PMHC certification that Caitlin was talking about, and kind of and figure out how we can identify that in our billing systems, which is a very good, very reassuring first step. And over time, that can maybe mean things like reimbursing them, which means providers might be more incentivized to get further training in this. So while it's not all great, it is still looking up in the sense of hopefully we are moving forward and we're not as far behind. And we have a lot of positive energy in the state to get things done, which is great. I'm going to jump to slide 10, if that's okay, because Caitlin has kind of covered a lot of sort of the perinatal mental mood and anxiety disorders and sort of their prevalence. And it's highly prevalent, way more prevalent than things you get screened around. Like when you get pregnant, there's like all this probing and prodding and wands and peeing and things and all of that from the medical system. But the entire medical system's juggernaut comes to a screeching halt when it comes to screening for mental illness, for example. And I want to kind of focus on sort of the cost of it, because sometimes depending on who you're talking to, the cost matters. And the cost of untreated depression per mother-baby dyad is about $32,000 per year. If you were to look at Arizona, that cost translates to $477 million a year if nobody's treated, but that's not the case. Some people do get treatment. And if you take the sort of liberal approaches to people got treated, 20% got treated, which is not actually the case. The cost of the state is about $375 million. And this cost, next slide, is not just on the cost of, these are costs that are variable kind of costs. So some of this cost is based on economic impact. Some of this is child abuse, neglect, lost productivity, inappropriate use of medical care. So it's kind of a variety of costs, which is also why this kind of data is really hard to find, because it's hard to kind of filter out all of that cost. It's easy for us to say, this person got hospitalized and the cost of that psychiatric hospitalization was so much, but it's very hard to quantify the cost of the relationship impact. So this is the best we can do, but it's unlikely to be a good sort of true cost. And this kind of cost we see replicated across other places as well. The other things that we'll see the cost in is physical cost, right? There is increased risk of miscarriage, hemorrhage, gestational hypertension, suicide, as Caitlin mentioned, poor nutrition, bonding difficulties, difficulty with the maternal health themselves, any depression, anxiety, mood disorders, mental health issues. They tend to have this sort of ripple effect. They kind of affect every sphere of your life. So your personal care, your immediate family, your finances, your social support, it kind of just ripples out to that impact as well. And the very real impacts in terms of impact to the child, for example, risk of preterm birth, NICU admissions, low birth weight, long-term associations with poor attachment and the consequences and sequelae of that. The poor attachment data we've had since 1970s, I believe, that there is that sequelae of maternal attachment. And of course, there's the multi-generational impact to it. Communities are affected because of loss of economic productivity and other sort of mental health expenditure. We could go to the next slide, please. And this is a challenge because, again, as it's underdiagnosed and undertreated. For depression alone, which is not the most prevalent perinatal mood and anxiety disorders are more prevalent than depression. People just tend to think of depression more. 60% of women are never diagnosed. And those that do get diagnosed don't get treatment. So about only 20% of people end up getting treatment. And healthy families lay the foundation for a productive society. And despite the prevalence of mental health issues and substance use disorders, this is a pretty high level of people who are not diagnosed and treated. And part of that is we don't have the volume of people to take care of them. So if we go to the next slide, this is a map of healthcare, mental health care shortage areas in the US. So these designations are to identify areas and populations within the US that have a severe shortage of health professionals. And they're generally three categories: medical, dental, and mental health. And this is the mental health survey. As you can see, Arizona's on the lower end of sort of the coverage, and you kind of need a high amount of providers. Let's look at some Arizona specific data. So when you go to the next slide, this is the behavioral health workforce map for 2020. I want to make sure that you guys realize that this is the data that we can track. So some of this data is from licensing boards, et cetera. So this does not include nurse practitioners, which I keep telling myself it doesn't include nurse practitioners because it makes me feel better. That is probably bigger than what we're looking at. But we have pretty low numbers in our state, and not just low numbers, the spread is problematic. So as you can see, the highest spread is in Maricopa, which we expect, with a slightly higher in Pima County. And then from there, it just becomes kind of dismal, which is a challenge. If you are a provider in a low county with no other providers, the pressure on those providers to provide care becomes more and more. And then there is a burden on those providers, and then you can burn them out. And so people willing to continue to care for what is a tough population to care for becomes challenging. Let's go to the next slide. This is, again, sort of the urban versus rural breakdown. The blue bars are the urban. Next slide. In terms of the state in Arizona, the total number of psychiatrists in Arizona are 915, which is less than 1,000 psychiatrists. And so there is a huge variation in capacity. What we're trying to do is find out how many of these psychiatrists actually accept insurance, because a lot of psychiatrists will do cash pay. And of those, how many are trained in reproductive psychiatry? And so hopefully we'll be able to bring that data back to you guys at some point. But it is a very small amount of workforce. So if you're hoping that patients with maternal mental health issues will get seen by a psychiatrist, that's not going to happen anytime soon. Hopefully, as we are funding, as the state is funding more residency programs for psychiatry, I think we've got 3 new programs in the state coming up, 4 actually. We will be building that pipeline, and that's great to have that long-term plan as well, but we also need a now solution and a short-term solution. And I'm going to skip the next 2 slides because I know that you guys wanted to have more time for conversation. So what I want to make sure is we think about the idea that we're thinking about who's going to take care of this population. This map is the population of OBs. So this is frontline providers in terms of OBs. Their numbers are significantly higher. And this is one of the ways to think about the care for maternal mental illness. It's a highly complex disease process. There's so many layers to it. And one of the things I'm presenting is just one of the levers we're going to pull at. And of course, we got to kind of keep working at it from every angle. And one of the things that we're thinking with that we are doing with APAL and that I'm pitching to you guys today is to think about reworking who takes care of this population. So most of the mental health conditions right now are treated by primary care. When it comes to that pregnancy consideration, a woman will see a healthcare provider an average of 25 times during the 2-year time frame from conception to the baby's first birthday. So they will have a lot of contact with frontline providers, and there are regular opportunities to screen and treat. The problem becomes frontline healthcare providers at times don't always have the training, knowledge, resources, or time to treat mental health conditions. And they're not also reimbursed for treating those conditions. So this is not exactly a tempting scenario. They do it, but also I've met with so many people that are like, I'm not comfortable doing it. I'll do it for my patients. I wish I had another option. So it comes to the idea that we need a solution. I'm going to jump a few slides ahead. Next one. Thank you. And so one of the levers that we're considering pulling in terms of addressing maternal mental health is to build the frontline providers' capacity to increase care. And the way to do it, next slide, is psychiatry access programs. Psychiatry access programs were started with child psychiatry access programs, and the first maternal mental health perinatal psychiatry access program was launched in 2014 in Massachusetts. And funnily enough, they used to have a child program. They had a little bit of leftover money, and they were like, oh, what do we do with I think it was less than a couple $100,000 or something like that. And so they launched the Perinatal Psychiatry Access Line, and they have a few different arms to their line. So education, in which they go and do free trainings to frontline providers, their teams. They will do direct consultation, which is somebody calls and says, I'm a family physician. In my office is a 5-month postpartum patient who has relapsed on opiates and has perinatal anxiety disorder. What do I do? And they can directly talk to a reproductive psychiatrist who will talk them through the case, talk about what the options are, what the reproductive safety of meds are, what are the other things to consider in the management of this case, and also send a consultation note, depending on the state, that either send consultation notes or don't. And then the third arm, which varies across state to state, is the resource and referral arm. MCPAP, the Massachusetts program, for example, has a resource and referral arm that they will try to send out referrals to different sort of systems within their state. But Massachusetts runs healthcare very differently. So they're a very practice-based system. Washington, for example, is very similar to Arizona in how they practice medicine. There's a lot of independent practitioners. It's very, very large comparatively, and they don't have a resource referral arm. Wisconsin, for example, does not have a resource referral arm as well. Next slide. The other thing is whether this program works. So does creating a program in which the frontline provider has direct access to a specialty that is very rare and can guide them directly actually work or not? And so I'll talk to you about it in a few ways in terms of looking at whether it gets utilized and the cost of it. When MCPAP kind of looked at the volume of encounters and how feasible they are, it ended up being 70 cents a month per woman, per birthing person. So per perinatal woman, not all women, per reproductive age woman for the state. And since Massachusetts has about the same live births as Arizona, we can kind of assume that we'd have probably similar cost. But the more important question is, does it actually work? And they have had a look at sort of utilization and quality assessment. So they did focus groups and surveys, and they found that clinicians who utilized psychiatric consultations most, and especially did so longitudinally, had strong predictive associations with providing direct mental health care to patients with severe mental illness, such as bipolar disorder, along with sort of the less severe mental illness like depression, anxiety. By no means are they less severe or less impactful, but for example, people became more comfortable providing that care as well. So utilization was also helpful. They also did comparison studies with regards to doing MCPAP versus short-term programs in which they're providing direct patient care. In MCPAP, the improvement difference between sort of direct short-term care versus the MCPAP program, which is not direct care, was not notable in terms of one being more significantly better than the other. Next slide, please. So June 1st, 2.5 months ago, we launched the Arizona. So these are all the other lines across the US, and now Arizona is on the map. Next, please. And we are the Arizona Perinatal Psychiatry Access Line. We've just finished our 4th trimester, and we're starting to get into a groove. And one of the few things that we do is provide trainings. Next slide. And what we do in terms of trainings is that they're free. You can reach out to us on our website and say, come do a training for our hospital group, our provider group, my frontline team, my nurses, whatever it is, we will come and do it for free. We're working on providing CEs and CEUs for it. It's turning out to be a little bit more challenging than I thought, but we're working on it. This is the list of provide trainings on our website. If there is something that you are like, I really want to learn about this for our team, let us know. We will try to put one together for you, because part of the goal is to build that frontline capacity and education for the state of Arizona. So we're in the middle of building some of these trainings as well. Next slide. The main function, of course, is the consultation. So our phone number is 888-290-1336. Right now, we're halftime, 12:30 to 4:30 in Arizona for the state of Arizona. In November, we're going to go to full time, and we're hoping that once we have figured this out, we can kind of negotiate figuring out a child psychiatry access line, because there's so many providers that are taking care of full families and are like, okay, I can take care of one piece, but I would also like guidance around the other. And we take calls from everyone. So I've gotten calls, psychiatry, OB, emergency medicine, family medicine. It's kind of been the gamut across the state. And so it's a very lean setup when you think about it, because we've got about 1 FTE of psychiatry, and that's serving the whole state, which is a very, very efficient way to serve the state. However, what I do have is a request to all of you is to get this information out to your networks. I want to make sure that we're reaching all the counties, and I feel like we haven't. And so if you can help me get the word out so people can call us, it's a free service. It's very equitable. I don't care what race your patient is or what insurance they have. It doesn't cost anything to the patient, to the provider. So if we can be of help, we would love to be of help. And again, we'll support mental health and substance use disorders. The other thing, next slide, on our website is a county-based map on resources. So you can refer your patients to that section on the website. They can look at the map and kind of go through those options within the map as well. And the last thing I will say is that if you're thinking about resources in general, Postpartum Support International is a huge ally for us, and in general when it comes to maternal mental health. So they have a bunch of online groups, over 14 specialty groups, over 5 days. They have Chat with Dad is first Monday of every week. They have English, they have Spanish, they have multiple subgroups that are available, things like pregnancy after loss, things like Black Moms Connect. So there's a lot of subgroups within their support as well. A few other things that happen in the state, in-home family support, which is nurse-family partnership, community healthcare program that connects families with a nurse family visitor, and it serves Maricopa and Pima County. There is the Health Start program, and that's free home visitation program that works with pregnant women, mothers of young children and their families, and they have translation services as well. And they will follow up to 24 months of age, which is also nice sometimes to have. Pima County and other counties have parent coalitions. And so in those setups, they have in-home classes, community classes. There is a birth to 5 helpline. All of these will be in, all the things that I'm talking about are going to be in the slides that will get sent out. So don't worry that you're trying to write these down. You don't need to, they'll go out with the slides as well. There's another program that's starting out, right? That's a program for Arizona Youth Partnership. And that provides health education, supportive services to pregnant and parenting adolescents, which are 21 and younger. And they have case management, support group, pregnancy classes. They have a scholarship class. They also do like a gently used corner of clothing. And I'm sure everybody knows about 211 Arizona because they provide a wide range of services such as housing, shelter, rent, employment, all of that. And I think a few things to always keep in mind is the Arizona diaper banks. And there is a care resource and referral system that provides statewide services. I've actually had a lot of luck with the care resource and referral system because I've had patients that are stuck in very difficult life situations, living in homeless shelters, but they just had a baby, so they need childcare so that they can go to work and get back on their feet, because childcare is ridiculously expensive. And we've been lucky in terms of being able to get childcare paid for like 3 to 4, 5 months with the state, which allows people to get back up on their feet, which is the other piece of taking care of them during this reproductive time period so they can kind of get back up. I'm going to stop talking and stop sharing the slides because I'm looking at the time and I know that you guys wanted some conversation time.
So those were incredible resources though, Dr. Kalia, thank you. And as she mentioned, we will be getting the slides out to folks after, so you can have a listing of those resources, including the links to PSI and APAL, where those resources are listed as well. Thank you both so much for just the incredible comments, a wealth of information that was just really, really meaningful to everyone on this call. I'll remind our participants, you can add questions or comments in the Q&A section. If you've got questions for our presenters, but I've got a couple that I'll kick off with first. So you both discussed specific training related to maternal mental health, but can you share a little bit more about why general mental health training isn't ideal for postpartum or the perinatal period?
I will, Caitlin, you want to take that one? Or do you want?
So it's nuanced. It's different. Everything about the reproductive time period is just different. And I think the best way to answer this question is to kind of give a brief example. And I will preface this with, number one, I have permission to share this. And number two, I've changed all identifying information about this person. But there is a Arizona resident who was experiencing postpartum intrusive thoughts, which is a very hallmark, normal, common, I would say a very common aspect of postpartum OCD and other kinds of postpartum, mood anxiety disorder presentations. And she was seeing a mental health provider who had no training in perinatal mental health, who sent her to the ER, where she encountered other professionals who had no training in perinatal mental health. And they misunderstood her symptoms, and she ended up getting separated from her baby for 3 days, put on a 72-hour hold. She wasn't given a breast pump, and that experience caused such severe trauma that it was more traumatic than the original intrusive thoughts that she was experiencing. So I get that's one example, but that kind of stuff happens all the time. It's different. It's different. The needs are different.
Yeah. And I served as the associate training director for the psychiatry residency program in Tucson for 6 years. And I've had a lot of contact with other training directors for psychiatry residency. So I'll speak from that perspective. Perinatal specific education is not required as part of regular psychiatry training. It is recommended, but is not required by the state sort of the ACGME, the national governing bodies. That's where there's a lot of push to make that required, but it isn't. Similarly, when you look at emergency medicine does not require you to rotate in psychiatry. So if you're an emergency medicine doc, 40 to 60% of your patient population is psychiatry. And depending on the program you train at, you get a lot of exposure, get a lot of on-the-job training, but you're required to actually work within those systems. And some places have great supervisors and the docs have a lot of training, but some places don't. And that becomes challenging in that nuance of it all. Additionally, it is not the same thing. Pregnancy is designed to get rid of every toxin. So in your regular, if you get pregnant, all your liver enzymes are going to rev up. So anything that is so it's going to go up by 40 to 50%, which is a huge deal in terms of thinking about just medication management. So if you're not thinking about the fact that this is a huge shift from a psychological perspective, from a physical perspective, you don't have that training. And then there's nuance within how your body reacts and how you react from a psychological perspective. That is hard. And I think it's not fair to demand that of providers who have, honestly, frontline providers have a lot on their plates already. Medicine is not simple to practice anymore. And so I think it doesn't suffice. It's not enough. So it's necessary to kind of add on. And honestly, we do that with everything. We've added that on with substance use disorders. There's state level requirements around getting further training and making sure that you're up to date. And this is just kind of like that, if that helps.
That's very helpful. Yeah, thank you both so much. And you shared a wealth of resources information, both of you, on resources for pregnant and postpartum individuals. One of the questions I had though is we've got a very diverse birthing population. Do you have thoughts around ensuring culturally appropriate support and services for our Indigenous population or our tribal birthing people?
See, now that is a very challenging question to answer because we don't have, when you look at sort of health equity versus health disparity in general health, it's challenging enough. When you start to look at maternal health, there are stark ethnic disparities and racial disparities in terms of outcomes. So that is a huge problem. The other part of that problem becomes in terms of when you look at the US, 26% of the population are members of groups that are traditionally underrepresented in medicine. So African Americans, Hispanic, American Indians. Only 6% of practicing physicians come from those groups. And so it becomes very challenging to say, provide care for people who match what they look like. And they are clear in terms of outcomes, in terms of how they respond. That being said, there is more and more data that's coming out. I think there was a recent article that came out about female surgeons, how female surgeons have better sort of 30-day mortality rates. And so I think this is more of a system level piece where you bring more diversity in the system on every level, and that will ripple out. And that is, and you do that now. Also, you do investing into the future, into bringing those people up. And we don't, and so we kind of have to work at it at every angle. We can't be like, well, we're working on building that pipeline. That pipeline is going to show up in 20 years. And so thinking about building it in the now in terms of bringing diversity in, and sometimes thinking about changing systems now. So if we know, for example, pain management with African-American patients in labor is different, is not adequate. And so can our electronic health records be adapted to say, ping it to say, we noticed that this patient is African-American. We noticed that you're doing this dosing, which is not standard, just an FYI, so that we can, as we're encouraging things like implicit bias training and diversity training in medicine across the board, we're also helping providers to stay on top of that. Because again, I don't think anybody has bad intentions towards their patients. I think you have to help everybody kind of get to the spot that they all want to be at. And so while I wish we had more and we are building more, we also need to kind of think about the now of it, which I don't know if I answered your question, but I'll turn it over to Caitlin to fill in if I missed anything.
Yeah, I mean, I will just add to that I mean, yes, it's a huge problem, and the now is pretty bleak because what we're building is for the future. And two things: PSI has incorporated a cultural humility piece to all of their training, so it's not sufficient to meet the need of having completely culturally relevant services in our state. But that is, one small piece. And then, I briefly mentioned the BIPOC training. So that's kind of another thing that PSI is doing to really create diversity in creating culturally relevant services for birthing families in Arizona. And, we gave out over $40,000 in scholarships for people of color to attend training, advanced training, and sit for certification exams to get their PMH-C. So that is at the top of PSI's mission for this year.
I think one thing to note is that was the first national BIPOC training that was held in Arizona.
First ever. Yep.
First ever, first national. It hasn't happened before, and we've already got one planned. I believe I got an invite for it. So
April 2024. Yeah, we're hoping to do it annually.
Yeah.
Yeah.
That's incredible. Just what an outstanding contribution to the state. So thank you both for that. I'll ask one last question before we wrap up today. You all shared a lot of different tools and strategies, and we know that this expands beyond the maternal health continuum and the traditional maternal care space, and really would be benefit for all provider types. As you mentioned, there's a lot of visits that happen with birthing people for 2 years, right? So do you have recommendations on how to gain engagement across providers outside of that traditional maternal care continuum in understanding these resources, tools, services?
I think healthcare systems have a bit to play with that. I honestly, I feel like there's a lot of pressures on OB providers, family medicine, emergency room. Like if you look at the workload and how that workflow is, it's heavy. If you look at private practice, people who are in the community providing mental health care, their days are heavy. Like to see 8 psych patients or therapy patients back to back for 8 hours is exhausting. It's emotionally exhausting. And to put the burden on individual providers is not fully fair, because they have their lives also. And to be like, well, now on your in your free time, please go and learn on your own. So I think it has to be hospitals, healthcare systems, insurance systems that are saying, let us make it easy for you. Let us help you figure out, these are the resources, these are the education, this is the training. We've set it up for you so that they don't have to do the work of finding it. And I think we need to help our healthcare providers, because people mean well. We have good docs who really care about our community. And that's why Arizona got a C out of, national grade average of a D. So I think making it simpler for our providers would be a way to help them engage. Because I really, truly do believe that people mean to care of their patients and they're frustrated that they can't.
Yeah, and if there's a way to implement any sort of screening into just like the standard workflow of, intake forms and things like that, the Edinburgh postnatal depression screening is a very valid, brief, easy screening tool that, any OB office or any pediatrician office could ask, the parents to briefly fill out with just a resource list. And, as part of the education training committee of PSI Arizona, that's one thing that we're really investing a lot in right now. We're offering a free sort of like lunch and learn kind of, it's not a CEU thing, but it's a, if you want us to come and talk to your practice or whomever, myself or another one of the board members will come and talk to you about, just reproductive mental health and, how to kind of make adjustments within your workflow to better screen and, kind of catch some of these things.
Wonderful. I can't thank you both enough, Caitlin, Dr. Kalia, for being here today and sharing all these phenomenal resources. I'm excited to see everything that's happening around the state in this area. For those who participated today, we will have an email that comes out afterward that shares resources, including information about the BIPOC training that Caitlin shared. And also please stay tuned for a link to a survey so that you can redeem your CEUs for this event. Finally, I'd like to invite you to save the date for our next Arizona Community Grand Rounds, which will be on Wednesday, October 11th from 12 to 1. We have a very exciting session, Transforming Mental Health Service Delivery, a conversation with Dr. Tom Insel, which should be just a really phenomenal session as well. So thank you all so much for your time today, Caitlin, Dr. Kalia, for putting all of this together and sharing all these great resources with us. And I wish everyone a happy Wednesday. Thank you.